Hello and welcome to another CPT Surgery Coding Review. We are looking at the 30,000 series in this video, and this is the 30,000 series part 2. In part 1, we covered the respiratory system, which is the first part of the 30,000 series, and today we're going to jump into the cardiovascular system, which begins on page 209 in your 2020 CPT manual. I think it's important to note as we enter the cardiovascular system that it is a very complex system. Hands down, probably going to be one of the hardest systems that you're going to work with. And on a personal note, I will tell you that I have had training in certain types of cardiovascular system coding that I'll share with you very shortly here. And even after extensive training for a week by a physician, with experience, it was still very overwhelming for me. And really, truly, the only coders that are very comfortable with cardiovascular system coding are either those individuals that do it every day, or those individuals that have a really advanced knowledge of cardiac terminology, anatomy, physiology, disease process. Because the cardiovascular system as a system is very extensive and has lots of terminology that you unfortunately will not learn overnight. So in this portion of the this series, we're going to start the cardiovascular system. The cardiovascular system is divided into heart, pericardium, and then the arteries and veins. So in this video, we'll probably just be able to get through heart and pericardium, and then I'll come back and do arteries and veins. So patients that are going to be receiving services in the 30,000 series, specifically, let's talk about heart and pericardium, generally have some type of heart disease, also known as cardiovascular disease. And generally with heart disease or cardiovascular disease, we're talking about a range of conditions that can affect the patient's heart. And under the umbrella of cardiovascular disease, you're going to see things like blood vessel diseases such as coronary artery disease. That's when the arteries are clogged up and the blood cannot flow like it is designed to do. Other conditions your patients may have heart rhythm diseases, also known as arrhythmias, which means that the rhythm of the heart is not beating like normally. And then also patients can have conditions that they're born with, also known as congenital diseases. So as it relates to the heart and pericardium, I think it's important to kind of review the purpose of each. So as I'm sure you know, the heart is an organ that it's a pumping system, and it pumps blood throughout the body. In conjunction with the respiratory system, the cardiovascular system, the circulatory system, supplies oxygens and nutrients into tissues and removing carbon dioxide and waste. The pericardium is a thin sac that actually surrounds the heart, and it actually protects and lubricates the heart and keeps it in place within our chest. And sometimes the pericardium can become inflamed or fills with fluid, which in turn, it can swell and damage and affect the function of the heart. All right. So, on page 209, again, that's where the cardiovascular section begins. We do have a table of contents, if you will, with regards to the heart and pericardium on 209, 210, and then 211. That's where the arteries and veins are. Again, probably won't get to that today. But then I want you to notice that there are some diagrams that are in this portion of the CPT manual on page 212. You have the arteries, and then on 213, you have the veins. And so here, my friends, this is why this is such a complex area, because if you look at just the arteries and veins alone, it's a lot of them. And if you were to ask me, with close to 30 years experience, take out a piece of paper and write down all the names of the arteries, all the names of the veins, I probably could come up with half. But do I know what each and every one does and where it's actually located? Some yes, some no. So I want you to keep that in mind, that unless you're doing this type of coding every day, for 5, 6, 7, 8, 9, 10 years, it is going to be a struggle when you're learning the process, learning this system. And I just want to be honest, because I think this is the portion of the CPT manual that a lot of people get very frustrated about. And I think it is just important for you to know that it is challenging, and it does take time, and it does take research. So we're going to go on over to page 216, and at the very top it starts off with subsection note under cardiovascular system, and it starts to talk about vascular catheterizations. And so I think it's important to kind of level set some of the terminology that you should know for this area, which they mention names in the subsection notes, but they don't necessarily define what they mean. So whenever you see the term vascular access is basically going to be the location where the doctor is going to enter the patient's vascular system. So that's the area that they access to catheterize the patient. Vascular family is a vessel that arises from the aorta or is off the axis of a vessel, and then it includes all of the vessels that branches off from it. So when I think of a vascular family, I think about a tree. And the base of the tree is what's that called? The trunk, right? So I compare the trunk to the aorta, and as the aorta, as you go up anatomically from the aorta, you to the left there's the superior vena cava. To the right, there's the pulmonary artery, or depending on how you're looking at the diagram, but you get the point. And so as you go up the vascular family, like climbing up a tree, the branches get thinner and thinner, right? Till they get to like the little twigs. So the vascular family branches off the aorta, or where the doctor accessed the area, and it includes all the little vessels. Now, for vascular family, for a visual, of course, you have the internet, but in our CPT manual, I believe it's Appendix L, page 856, there is actually a diagram that shows you what's meant by vascular families, okay? Vascular order is a term that you're going to hear, and order is going to describe the level of the vessel. So in the CPT manual on page 216, there's a note that says selective vascular catheterization should be coded to include introduction and all lesser order selective catheterizations used in the approach. Then they give you an example. I don't know about you, but I'm visual. So I'll give you a picture shortly, but I want to get through these definitions. And then we have the first word that's listed in the CPT manual, page 216, the term selective catheter placement. So two terms you're going to see used when they're talking about vascular families is the provider selectively catheterizing the patient versus non-selective. So selective is where the catheter is placed into a branch off of the aorta or access the vessel. And then each of these vessels, again, that arise from the aorta, get a picture of the aorta, or the vessel represents the family. So the physician is actually selectively placing that catheter. Whereas non-selective catheterization, that's basically where the catheter remains in the excess vessel, or it has made it into the aorta and it stops there, which is still considered non-selective. So once they get into the different branches of those families, that's when you're going to get into selective. So I mentioned about order, and here's a picture that a lot of coders that work with this specialty use. One of the things that you probably notice is that there's a picture of the lower extremities, and you'll notice that there are lots of words popping out from this diagram with CPT codes next to them. And essentially what they've done in this diagram is help the coder pick which code would be used for a particular vascular or a vessel. So on this diagram in the right-hand corner, you see where it says non-selective, first order, second order, third order. So we talked about non-selective. That's where the catheter remains in the access vessel or has made it into the aorta. Whereas selective, the catheter is placed into a branch off of the aorta or the access vessel, and they're going into the different vascular families. And again, if you look at Appendix P, you'll see what we mean by first order, second order, and third order. All right. So let's get into some code. So we're still on page 216, looking at pericardium. And we've already defined that pericardium is a thin sac that surrounds our heart. It protects and lubricates the heart. So what you're going to see on page 216 are procedures specifically for the pericardium. So they start off with pericardiocentesis, and you know centesis is a surgical puncture into a vessel to remove fluid. So here they're removing fluid from the pericardial space. Now you'll notice that this first code 33016 for pericardiocentesis includes ultrasound or imaging guidance. And in this picture, I actually have, you see where the ultrasound transducer and the needle that's being used to perform the pericardiocentesis procedure, just to give you a visual. One of the things that I just highly want to just re-emphasize with you regards to surgical coding, it is critical that you have a picture, that you watch a video, that you understand what you're coding, and that you're not just coding words. After that, we have two codes for pericardial drainage with insertion of an indwelling catheter. You'll note all the things that are included in this code family. The major differentiation is the age of the patient. And if you have not done so, one of the things that I highly recommend that you do is consider whether or not you want to bubble your CPT manual. There is a YouTube video out there that you can watch, BHAT, BAT technique, for bubbling your CPT manual. Take a look at it, see if it's something that you feel like will be beneficial for you in marking up your CPT book. But again, please don't over mark up your CPT book, because you don't want to have too much traffic, too much noise going on in your manual on the day of your national exam. Then after that, we have pericardial drainage, also with insertion of an indwelling catheter. And I want you to notice the difference between 33017 and 33019. Next after that, we have a pericardotomy, which is where they're removing a clot or a foreign body. We also, after that, have a code for a creation of a pericardial window. And one of the things about when you're looking up some of these procedures, sometimes you'll get to like the respiratory system as opposed to the cardiovascular system. And so it's good to just know where things are in the manual in case you get lost in the index and you need to just go right over to that code family. After that, there is a pericardectomy. Notice this is subtotal or complete. The major differentiation here is whether or not cardiopulmonary bypass is used. You're going to see in a lot of the code families here that a lot of them are differentiated based upon whether cardiopulmonary bypass was done, because a lot of procedures, they have to put the patient on the heart-lung machine in order to safely do the procedure. Last code is a resection of a pericardial cyst or tumor. Also want you to note that there's a parenthetical note that tells us if they do a thoracoscopic resection of a pericardial cyst or tumor, they want you to use 32661, which is actually over in the respiratory system. All right, so we are climbing right along. And next up, let's go over to page 217 in our CPT manual. And we're going to be looking at pacemakers. So again, I cannot overemphasize the need for you to understand from a clinical perspective what your patient is having and why. Because if you understand why somebody's getting the procedure done, then you understand what the procedure is all about. Reading through the operative note gets a little easier. But until you code about 2, 3, 4, 5,000 operative notes, you're going to be learning. And even those of us that are coding day to day, we're still learning because something new always happens. All right, so on page 217 and page 218 and 19, there is lots of information about pacemakers or implantable defibrillator. So as illustrated on the diagram over here on the left, and everybody knows which one we're talking about, this one here. A pacemaker is actually a small device that's placed under the skin into the patient's chest to help control the heartbeat. So if you're looking at this diagram here, what you'll notice right here, I'm gonna put a little arrow here, that is what's known as the pacemaker. Notice it is under the skin and it's in the chest wall, exactly. So a pacemaker is a system that is designed to help the patient's heart beat. In particularly if the patient has a slow heartbeat, such as the condition called bradycardia, meaning slow. So this is a surgical procedure. It basically helps the patient keep the pace. That's why they call it pacemaker. Now, an ICD or implantable defibrillator is also an electronic device. It's connected to the heart, and it's used to continuously monitor and help regulate potentially fast and life-threatening electrical problems within the heart. So it's kind of like something that's in the heart that just gives the heart a jump when the device senses that there's something going on with the patient's electrical system. And so as you can see in the diagram here, and let's get a arrow pointed to this. This little device is about the size of a stopwatch. It is implanted under the skin just below the collarbone. And it has some components to it that makes it work. And so let's talk about that next. So, and this is actually covered on page 217, 218, 219. So I'm giving you the high level version. But these systems, the pacemaker system, the defibrillator, they include a pulse generator, which is the battery, and then one or more electrodes, also known as leads, also known as wires. Now, from the perspective of pacemaker, there are two main types. There's a single chamber pacemaker, and then there's a dual chamber pacemaker. The single chamber pacemaker includes a pulse generator and one electrode, henceforth single chamber, because it's going to be the lead, the electrode, the wire is either going to be inserted into the atrium or the ventricle. Typically, not always, it is the right ventricle of the heart that is used for this procedure. A dual chamber pacemaker, you notice I keep saying the word chamber. The heart has 4 chambers, the upper and the lower, so the atrium and the ventricle. So a dual chamber pacemaker, this is when the leads or the electrodes are going to be positioned to carry impulses to the right ventricle and the right atrium. Okay, and this really helps control the timing of contractions between those 2 chambers. Now, sometimes patients may need an additional lead outside of the atrium and the ventricle. And it's generally people who have heart failure and they also have abnormal electrical systems. They may need what is known as a biventricular pacemaker. Now, I don't have a picture of, all the different options, but terminology is going to be important here. Now, the implantable defibrillator, it also has a pulse generator. It also has the electrodes, also known as leads, also known as wires. And in both of these, the pulse generator, guys, is like a battery. And I think of, for the defibrillator, I think of if your car battery dies and you need to jump your car, the defibrillator is essentially jumping the heart. Okay. The other thing about the ICD and the pacemaker as well is that they can record and store information about the patient's heart rhythm and sends it to that doctor for review. All right. If you turn over to page 218 in your CPT manual, there is a table that is, I think, very user-friendly and very important for you to take note of, because this table really helps us come up with what code family we're going to be utilizing for a particular patient. So you keep hearing me mention pacemaker and implantable defibrillator. Well, on page 218, what you'll notice is that the table on the right side of the table says pacemaker, and then it says implantable defibrillator. So that's important because when you're reading documentation, you need to know, am I coding the pacemaker or am I coding an implantable defibrillator? And so then from there in the table, and this is important from a documentation perspective in terms of getting the right code, was the device today inserted, replaced, removed, upgraded? And if you look on page 218 on the left-hand side, you'll see that the codes are divided based upon if it is the initial insertion, is it an insertion because they're replacing, is it a removal? And so I would take some time to read this because the codes are also divided based upon what they're removing, because maybe they're just removing and replacing the battery because the battery has gone bad, or the wires or the leads have gone bad, because that actually does happen. These typically don't last a lifetime. So then on page 219, the same codes that are in the table are then, of course, in the manual itself. Take some time to review them. I will tell you in my book for these codes, I have done some bubbling, primarily because when I come to these pages, I want things to stick out for me. For example, on page 219, I have a bubble around 33206, 33207, and 33208. This is my code family for insertion of a new or replacement of a permanent pacemaker with transvenous electrodes. And then it's divided into, is it a single chamber atria, single chamber ventricle, or is it a dual chamber atrial and ventricle? And so one of the things that you'll find is it's challenging to pick up codes when you don't really understand how that code family is set up. So very important, take some time and take a look at that. All right, next up, going to go over to page 224, and here we're going to look at EP, operative procedures. And EP is the abbreviation for electrophysiology. And electrophysiology is actually a specialty where the doctor studies the electrical activity and pathways of the heart. And EP studies can be very helpful to identify for the doctor what's actually causing the patient's irregular heartbeat. And with the electrophysiologic diagnostic test, what the doctor does is basically reproduce the patient's heart rhythm, gives them medications to then see what's going to control it the best. But also an EP study can be done before a patient gets an implantable defibrillator that we just talked about previously. So it could help the doctor determine what device is actually best for the patient. Now, in the CPT surgery section, you're going to find on page 224 that we have electrophysiologic operative procedures. So here we know what type of issue the patient has. So you're probably wondering, well, where do we have the codes for the actual EP tests? Those are over in the medicine section, and we are a long way away at this point. Not too far, but we are not looking at the medicine section in this particular page here. So just make a note for yourself that the actual test that's done to identify the abnormal rhythm, those are actually in the medicine section. All right, so over here, these codes 33250 to 33266, these codes are designed for the surgical repair of whatever defect that patient is having that causes that abnormal rhythm. Now, with these procedures, you'll notice that cardiopulmonary bypass is going to be a huge component, especially when we're talking about the incision procedure, which are the codes 33250 to 33261, because the surgeon has the chest wide open, okay? But when you get over to 33265, 33266, those are the endoscopic approach for the procedure. Now, what the physician does, in case you're wondering, is really kind of map the locations of the electrodes of the heart and identifies where the source of the arrhythmia is. And then after he does that mapping, he actually can ablate the arrhythmia. So you'll see in codes 33250, you see the word ablation. The other thing that I think is important for you to know is that there's another area that's not here. It's called percutaneous electrophysiology, and we'll see that. You'll see that later in the book. But that's all for the surgical EP studies. All right, next up, we're going to go on over to page 226. And on page 226, you have codes for heart valves. These are the heart valve surgery codes. Heart valve surgery is done to either repair or replace a diseased valve. And when they replace a valve, what you're going to see is that there's going to be some type of prosthetic heart valve that's going to be used. One that I can think of off the top of my head is the St. Jude prosthesis. As a refresher, there are 4 valves in the heart. There's the aortic valve, the mitral valve, the tricuspid valve, and then the pulmonary valve. So how the CPT manual has the codes divided is that they are divided based upon those different valves, starting with the aortic valve on page 226. And what you're going to note on this particular page is that as you go from the different valves, they have these names of these procedures, such as TAVR, TAVI. So let's take a look at what those procedures are actually all about. So as it relates to the transcatheter approach to these procedures, that's what the T is for. This is when the patient has a procedure that actually allows a team of physicians the ability to place a new valve within the patient's diseased valve. Usually on the team, you're going to see that there's a cardiac surgeon, cardiologist, an anesthesiologist. And what the new valve does is push the disease valve to the side and then allows them to put in that new artificial valve. Now, the TAVR procedure, transcatheter or aortic valve replacement procedure, is really less invasive than traditional heart procedures. And the doctor is going to enter the patient's valve in 3 different ways. There is transfemoral, trans means through or across, so transfemoral, transapical, or transaortic. So you've heard me mention this several times. As a coder, you gotta really get into the clinical aspect of the procedure, because it really does help you code better when you understand what you're actually reading. So if you're just reading over words, you really don't get the full you don't really get the full understanding of what you're actually reading. All right. So also in this diagram, you actually see a patient that has an open heart procedure, but then you also see the patient that has the minimal incision valve surgery. So key things here, know what valve the doctor is working on. So again, those 4 valves are, what are those 4 valves again? Let's go back over here. Aortic valve, mitral valve, tricuspid valve, and then the pulmonary valve, okay? And then also know if the valve was repaired or if it was replaced. If it was replaced, repaired, you want to look at the prosthesis that they actually use, and they usually will give you the name. St. Jude is one that, again, is off the top of my head. All right, next up, we have coronary artery bypass grafting, also known as CABA. And CABA is a procedure that is designed to improve poor blood flow to the heart. And generally, patients that need this procedure is typically those patients where the arteries supplying the blood to the heart tissue, which is known as the coronary arteries, are either narrowed, also known as stenosis, or blocked. And so, like, you've heard the term arteriosclerosis or atherosclerosis. In those particular cases, the patient having this surgery is going to lower their risk of like a heart attack. But a CABA can also be used in situations when emergency situations when the patient has actually had a severe heart attack. So the procedure itself, and I'm on page 231 in the CPT manual, the procedure itself involves the surgeon using blood vessels from another part of the body and then connects them to blood vessels above or below that narrowed artery so that they can bypass the narrow or blocked coronary arteries. I think of that of being on an expressway or highway and there's an accident, and you see an opportunity to jump off and take the streets, depending on where you live. Here in Chicago, we can do that. But you jump off, you take the streets, and then you eventually get back on. That's essentially what the doctor is doing by taking the blood vessels from another part of the body and then connects them to vessels that are either above or below. In your CPT manual, on page 232, they have some pictures of the procedure being performed. And then also you notice that I have a picture here as well. And again, this patient generally has a procedure where the arteries are clogged. Specifically, the coronary artery is clogged up, and the blood can't flow through like normal. All right, so what do you need to know from a coding perspective? Well, there's a couple of things. Number one, you need to know that CPT has codes that are used to determine or used to identify what vessels were used in this bypass procedure. So if the bypass was done using a vein graft, you're going to be looking at codes 33510 to 33516. Those are on page 231 in your CPT manual. You'll notice that they're numbered based upon the number of venous grafts that were used. Of note, there is something important on page 231. Second paragraph of the subsection note, which states procurement of the saphenous vein is included in the description of the work for 33510 to 33516 and should not be reported separately. So if you're reading in the report for a CABG and they're procuring the saphenous vein, it is not something that you should code, that you can code separately. So one of the biggest things with surgical coding is that coders often say, well, how do I know what to code or what not to code, what's included? CPT does give us some guidance in those situations. Now, if the surgeon does an arterial graft only, if you turn over to page 233 in your CPT manual, you'll see that we have codes 33533 through 33536 to reflect the arterial portion of the surgery only. Same thing, codes are divided based upon the number of grafts that are used. Subsection note on page 233, third paragraph states, procurement of the artery for grafting is included in the description of the work and should not be reported separate, except, and there are some exceptions. So again, with cardiovascular coding, you have complex anatomy, but then you also have all of these rules and regulations. And one of the things I would highly recommend that you do not spend weeks trying to learn or master cardiovascular coding if you're in a program designed to prepare you for a national exam, because if you spend all your time on cardiovascular and you can get those questions right, but you bomb the other ones, you don't pass the exam. So you want to make sure that you just, you recognize if you can get the basics, you have to move forward, because if not, you'll be stuck. All right. Now, in some cases, the physician does a combined coronary artery bypass grafting procedure. And when they do a combined coronary artery bypass procedure, that's when they're going to use arterial grafts and venous grafts. Now, coding here requires that we use a code from two ranges of codes. First, we're going to report the arterial portion of the procedure, and that's going to be with codes 33533 to 33536. Those are the ones that are on page 233. And then on page 232, they have some add-on codes 33517 to 33523 that's going to be utilized for the venous portion of the procedure. Okay, so the tricky part here is in the report, identifying what was used for the graft. Was it a vein? Was it an artery? Was it both? And then you code it accordingly. We do have situations where the patient has had this procedure and then they have to have it again. There is an add-on code that is on page 233, which is code 33530. And this code is used when the patient is having a reoperation of the CABG procedure or a valve procedure. We talked about the valve procedures a little while ago. So if it is a reoperation of a CABG or a valve procedure more than 1 month after the original operation, you're going to use this add-on code in addition to the code for the procedure. All right, so you heard me mention earlier, and go back over to page 231 in the CPT manual. You heard me mention earlier that procurement of the saphenous vein is included in the description of the work for the vein graft codes only, and the vein graft codes only are on page 231, 33510 to 33516. So procurement of the saphenous vein is included in the work for this service. However, if in the documentation you note that the physician does a endoscopic video-assisted vein harvest, you can code it separately with add-on code 33508. Now, I made this slide here with these tips. I call them tips, but it's basically, something to have to remind yourself of what codes you should be using given a situation. All right, that was real deep. Okay, next up, we're going to go over to page 236, and we're going to look at patent ductus arteriosus procedures, also known as PDA. And this is a heart problem that occurs soon after birth in some babies. In PDA, which is actually a condition, abnormal blood flow occurs between two of the major arteries connected to the heart. Before birth, the two major arteries, the aorta and the pulmonary artery, are connected by a blood vessel called ductus arteriosus. And this vessel is actually a very essential part of fetal blood circulation. So within minutes or up to a few days after birth, the vessel is supposed to close, because patent means open. So the vessel is supposed to close as a part of the normal changes that occur in the baby's circulation. However, the ductus arteriosus in some babies remain open, so they're patent, and this opening allows oxygen-rich blood from the aorta to mix with oxygen-poor blood from the pulmonary artery, and this can in turn put a strain on the baby's heart and increase blood pressure in the baby's lung arteries. So on page 236, we have codes for repair of the ductus arteriosus, and you notice the first code, it is differentiated by ligation. The next two codes both say division, but they're separated based upon the age of the patient, because this condition, although it is in babies, it can happen, it can be done on older patients or happen to older patients as well. All right, next up, page 237. We have thoracic aortic aneurysm codes, and an aneurysm is a situation when an artery wall in the aorta weakens, and as a result of the weakening of this artery of the aorta, the wall actually expands, or looks like a bulge as the blood is pumped through it. And so this causes that aneurysm. So here is actually, you can see this bulge here compared to the aorta at the top, which is normal. So on page 237, you have the different procedures that can be performed on the aorta for the thoracic aortic aneurysm. So please take a look at those. So one of the things you'll notice is that there is different ways to do a lot of these procedures. And so you'll want to be clear in what your doctor is actually doing, because the next set of codes that we have is called endovascular aneurysm repair. And this is a type of endovascular surgery used to treat diseases of the aorta, most commonly what's known as a AAA. And AAA is not the motor club company that picks you up if your car is disabled, but a AAA is actually an abdominal aortic aneurysm. All right, so from a code perspective, on page 238, you'll notice the different code options that we have available. There's lots of parenthetical notes, and these codes are divided based upon exactly where they're doing this procedure. I highly recommend that you go through the codes and become familiar with the differences between the two if you have to code them. Next up, on page 239, we have our heart and lung transplantation. For the respiratory system, I talked about the transplants in CPT have 3 distinct components of work. Same thing applies here with the heart and lung transplant procedures. There are 3 distinct components of work. So there is the cadaver donor procedure, then the middle procedure is called the backbench work, and then lastly, the actual transplantation of that device or that vessel. Next up, we have ECMO and ECLS. Those codes are on page 240. All right, so ECMO, or extracorporeal membrane oxygenation, is a way to provide breathing and heart support for patients that have critically ill lung or heart disorders. You see this a lot with babies. What ECMO does is provide the necessary oxygenation to an infant while the doctor is able to treat whatever the underlying condition is. Older children and adults can also use ECMO, but you actually see it a lot in infants. So as this diagram illustrates, what happens with ECMO is special tubes that are known as cannulas are put into blood vessels that go directly into the heart or the bloodstream. And the doctor actually chooses the size of the tubes based on the size, the age, the weight, and the reason why ECMO is being performed. And basically, the cannulas are going to transfer the blood from the heart by pumping to push the blood through the tubes to the machine, where the blood actually receives oxygen and the carbon dioxide is removed. And then the next after that, the blood is warmed to the patient's body temperature, and then the warm blood eventually goes to another cannula back into the body. So on page 241, in our CPT manual, what you'll notice that the codes are actually divided based upon if this is the initiation of ECMO, ECLS, is it subsequent, are they taking the patient off? Spend some time looking at the table on page 242. You'll also notice that it's divided based upon the age of the patient as well. All right, and lastly, on page 243, we have procedures for cardiac assist situations. And for cardiac assist, what you're going to commonly see is a device called a ventricular assist device. And the ventricular assist device is a mechanical pump that's used to support heart function and blood flow in patients that actually have weakened hearts. What happens is that this device takes blood from the lower chamber of the heart and helps pump it to vital organs, just like a healthy heart would. And that's why it's called a cardiac assist device. All right, guys. So on page 244, what you'll see are ventricular assist device. You'll see codes for insertion, removal. They're also divided based upon if it's extracorporeal, so outside of the body, or if it's implantable, intracorporeal. So take a look at those and you'll be able to select the codes. All right, so as I mentioned at the beginning, I knew that I would not be able to get through all of the cardiovascular system, so I'm going to stop here with the heart and pericardium. I'll come back and do another video where I'll walk through arteries and veins and the rest of the 30,000 series to wrap up the 30,000 series. Thank you so much.